One sec. So yeah, I am the CEO of and co-founder of OmniLife, and I got started through a connected purpose into this industry through my own personal experience. So I was at the University of Iowa at the time. I played football there at the University of Iowa, 50 pounds or so ago as a linebacker, and then I ended up in a motorcycle accident and lost. Had several career-ending injuries, but one of those was a paralyzed right arm due to a brachial plexus lesion in my shoulder, those nerves in the shoulder. And so I had a paralyzed arm for about a year, and I had a nerve transplant. And after that, it was about a year of recovery. I now have full functionality of my arm, and that was really the inception for my personal passion. And my uncle still is a heart transplant surgeon, but did pediatric heart transplant for a number of years at Seattle Children's. And so we started working together on a project to help him review organs, make decisions on organs, and to communicate and connect with his team and his patients to make sure that they got every transplant. His experience had led him to assume that there was probably some donated organs that weren't being utilized for a number of reasons, but communication being one common issue. And so that's when I actually met at the time Eric Paul, who was doing his PhD at the University of Iowa in health informatics. He was a computer science, machine learning guy, focused in random forest, clinical decision support. And he had a personal connection to transplant, being that 4 of his aunts have liver failure. And he was interested in understanding more about, why it takes so long to get a transplant, and what were some of the bottlenecks there. And he started looking at a lot of the data that's publicly available through UNOS or SRTR. And he started to do he basically decided to do his thesis on improving organ matching with machine learning. And it was that time we started to work together on our project. And so I will, did we?
So my apologies. I think it's the way that I've come into Zoom, and so it's not.
I will copy the link, and you should be able to, if I give you, send this in the chat, you should be able to open it up.
Okay, awesome. Okay.
And then you can share your screen, and I can go off that. But yeah, so we started working on a application with my uncle and several of his surgeon friends, and it was essentially a tool to help them look at the organ data, be able to not only do an objective review of the organ, but to be able to pull in that organ data, match it with recipient data, and run their own decision support algorithms outside of the, or in parallel to some other traditional allocation systems. So we weren't deciding who got what organ. We were just helping, once that match had been offered to the surgeon, to see if that organ was indeed a good fit for their patient. So it was that we developed the tool. It was successful initially. We ended up getting NIH funding. We applied for an NIH grant and got NIH SBIR phase 1 grant that turned that group of surgeons and a prototype into a 3-center study in the state of Iowa. And then we ended up, perfect. We ended up having a lot of success with that initial grant. We showed that we could increase, with this communication platform, we could increase the response time or the offer throughput, how fast an organ procurement organization could offer out an organ and place it at a center. And through that experience, we were able to increase the number of organs placed at the centers that worked with us in that study by a significant amount. So we published a research that got accepted into a couple journals, and that really set off the path for what we're on today. And if you just go through, maybe next slide. This is the statistic I'd like to talk about. So as part of this research, we started to think about and learn about, okay, well, what were some of the bottlenecks? And we did the research. We discovered that 50%, 54% in fact, of the donated organs authorized for donation, were not being transplanted. And so we started to dive into the reasons on why that was the case, and realized that one underlying common issue was that these organs were particularly marginal organs that weren't great, but not bad, were not finding a match. They simply placed, and if you go to the next slide, I talk a little bit about some of these breakdowns. there were, if you just think about this process for a second, and it's even more complex. We actually spent some time with Life Center Northwest really early on with their team up in Seattle, and they cover Alaska. They talked about the complexities of logistics and communication. So if there's a donor in Seattle and there's a patient in Alaska, for example, or Montana or Wyoming, these patients are not going to Seattle. In fact, that's the doctors from those areas, and the organs aren't coming to them either. What's happening is the doctors that represent those patients from those locations are flying into Seattle to pick up the organs and flying them back. And so if you think about the communication process, and you've got as little as 4 hours sometimes to be able to get, once the organ's been procured from the donor, into a patient. And so it's a very time sensitive process. And some of these bottlenecks were basically resulting in having too much time being spent on trying to figure out if it's a good organ or not. That simply, the way that the timing all worked out, there were so many bottlenecks around just getting the organ reviewed and making a decision that it took them out of the opportunity to move forward with the case because they lost too much time. And so if we could speed up the time of decision making, we could provide more opportunities for donation and transplant, and that would allow them to hopefully transplant more patients. And so that's really what kicked off the research. You go to the next slide. We talk about limited supply, but we also talk about growing demand. If we just take a second, first of all, we help with organs. We also help with tissues. We've moved into some tissue and blood work as well with these organ procurement organizations. But if you think about growing demand on the demand side, but what I mean by that is patients that need these organs or tissues. If you just look at kidney disease alone, there's over 30 million of individuals suffering from kidney disease. 100,000 people start dialysis every single year. Less than a quarter of them get successfully listed. And then if you look at the patients that listed, 1/4 of those patients listed die within the first year without even receiving an opportunity for transplant. And you go to the next slide. We talk also around the bottlenecks on supply. But if you look at just kidney disease alone, well, why outside of the social impact, which is most important and core of everything that we do, obviously there's other things involved with the adoption of technology, and one of those is economic as well as political influence. And in the economics, and also political in the sense that Medicare has such a big role. If just kidney disease alone, we do all transplants, not just kidney, but if you just take kidney, over 1 out of every $5 of our Medicare and Medicaid budget is going towards dialysis. And there's been some recent changes with the Advancing American Kidney Act from the Trump administration that came out last year and early this year that has for the first time aligned the incentives and changed the incentives for dialysis centers to incentivize transplantation. And so what's happened is there's been a huge in these transplant centers that we were helping streamline, or if you go to the next slide, actually, this will sum it up beautifully. I just made this slide because instead of talking about it, I knew to have a lot of time, so I wanted a visual to talk about it more quickly.
So sorry, it is not letting me go down there.
No worries.
Okay, so maybe tell us more about what's
the arrow keys.
What's that now?
Try the arrow keys. Do you have them?
I am doing that, and it's not working.
Okay.
So I don't know why we're having so many tech issues, but please maybe just tell us. And
yeah. So if you think about, I have this image of a bow tie, and essentially what it means is it's depicting two funnels: a supply funnel and demand funnel. And what we realized is that these transplant centers that really sit at the if you imagine a funnel and you think about the organs and them coming into the funnel to be transplanted, or the supply side of this marketplace. And you think about the other side, which is the demand, and that's patients that are waiting. Maybe they've been diagnosed with kidney disease, they progressed to end-stage renal disease. Perfect, right here. They progressed to end-stage renal disease. Along the bottom, you see that the supply side of this funnel is 24 to 72 hours from the time that the donor has passed away and the organs are authorized by the family, allocated, and procured. You're talking 72 hours max until the transplant event occurs where they've taken the organs and put them in a patient. On the demand side, you might have 5 to 10 years of chronic disease management, such as kidney disease. Then you progress into, sometimes if you don't catch it early enough, you progress into end-stage organ failure, and you start to do that through management of organ failure, such as dialysis, for 4 to 5 years. At that time, you get referred for transplant. And we've seen that historically, And it's especially now because there's so many people referring patients, dialysis centers referring patients because they've been incentivized to centers, that this is now taking over a year to just, once you've said, okay, you need a transplant, let's get on the list, it's taking them up to a year to actually get active on the list. And then once they're on the list, they're waiting anywhere from 1 to 5 years to get a transplant. So as you can see, that's very chronic on the other side. But it all comes down to a single point of time with a surgeon at 4 a.m. in the morning or 2 a.m. at night, waking up to a phone call for an organ for a patient. And they need to make this decision. And what we showed on that other slide is that they've got 30 minutes to make that decision, and they have to contact there's up to 3 to 4 different constituents that they have to get contacted. And there's over 30 phone calls in a matter of 30 minutes to collect and connect all this information, trying to get the patient data and the information from dialysis coordinators, from nephrologists and referring physicians, from the patient themselves and their caregivers, from the pre-transplant coordinator looking through the patient chart. But then they also have to contact the HLA labs, the OR, the supply of the organ procurement organizations to get more information on the donor. And we're helping them do all of that way faster. And as a result, we're allowing more transplants to occur. Go to the next slide. So these are, pretty horrible graphics. I need to get them to a graphic designer, but this is simply, you saw those different individuals that are part of this ecosystem and involved in making this miracle happen. And we're connecting all of the dots. Go to the next slide. And so we have several different products. We have a product platform that offers a suite of solutions. We have a basic platform that everybody connects to, but then we have individual modules that if you're a transplant center, you're oftentimes using OmniReferral, which is helping them look at the number of their patients coming in and trying to prioritize which patients to transplant based on illness and other factors. But you've also got OmniDonor, mostly used by the organ procurement organizations, to send out the information to manage that donor through that process. But then we also have OmniCare, which is really focused on, if you go to the next slide, focused on patients, providers, and so that's kind of our roadmap. We're getting ready now that we have a lot of this data. We are getting ready to, at the end of this year, be able to start to focus on how we can better help having a really good understanding of supply and where the organs are, and having a good understanding of the patients. We can help not payers, providers, and patients all get organs faster. And the payers being able to put their patients in the best hospitals that would maximize their individual chance of getting an organ the fastest. So helping with multi-listing strategies and helping the patient get an organ and a life-saving organ faster is ultimately the goal. Go to the next slide. So this just talks about some of the reasons why it's really important right now and how we've had a lot of tailwinds. We started off really kind of messaging focused, and there was a big kind of growing awareness of HIPAA compliance and interoperability and information exchange with Blue Button 2.0. And so we did a lot of work there, and that's kind of what got us started. And we built these individual modules, as I mentioned earlier. But we've had a lot of organ allocation changes recently that are making organs go farther than they ever had before, which increases logistical complexity. I didn't mention earlier, but around 7 to 9% of organs that are donated, which is anywhere from 5 to 10,000 organs, kind of depending on overall annual volumes of organ, which go up and down, are lost because of logistics reasons alone. So that means that the organ's been placed, it's been accepted for a patient. A patient's been brought into a hospital to receive their transplant, and they've lost the organ. The organ was damaged on the way over. They've sent the wrong organ in the wrong place. So those are just logistical mistakes that we're also kind of focused on improving as this market and this network gets more and more complex. And not on here is COVID-19, which really kind of added complexity to a lot of these teams working remotely and needing to figure out how do we have a better communication and how do we think, and these are now organizations and others who may be involved in healthcare and other areas of healthcare may be seeing this as well, is how do we come up with a communication strategy? What's our communication plan? And these are things people are talking about. The next slide. This is a little bit about our team. Go to the next slide. I can talk a little bit more about them later if there's any questions, but we've got a great set of advisors. And if you go to the next slide, we've got a growing investor syndicate. So we're privately financed. We've got notable investors like Desert Angels, Boston Harbor Angels, Wellmark, Blue Cross Blue Shield. And then if you go to the next slide. These are some of our current customers that are on the messaging platform. And so we also have an NIH SBIR phase 1 research grant that we did in 2018. And we just got awarded in late 2019 for an NIH SBIR phase 2 grant that's a $2 million grant, all in. And there's several research partners listed there that are participating formally in that research. There's actually, through UPMC and the Starzl Transplant Network, up to 12 transplant centers that are participating in that study. And I'll just end there and ask for any questions. Maybe go to the, I think, I don't know if there's a next slide, just to double check. I'm pretty sure that's it. Yeah. So thanks for your time, and I'd love to take any questions.
Well, what I would say is thank you, Dalton. Thank you for your grace under fire. Thank you for persevering through some tech issues.
No
that
worries.
is fascinating to me. Obviously, this is my first kind of understanding of this whole process, and I'm fascinated by what you've been able to do. So can you help us better understand more about the work that you've done? Again, you know, logistics really is a big issue for Alaska. I mean, can you maybe bring this back to us and how somebody in Alaska might be able to take advantage of OmniLife and how this will change? I know that there are many people here who need transplants. So how will this possibly change their lives?
Well, and this is where I was going to ask for some help as well. One of the things that we've focused on, so like I said, we worked a lot with our customer discovery initially with Life Center Northwest because of the geographic disparities that are so unique to this part of the country. We wanted to better understand, you know, with logistics and communication being equal is so much so important, particularly for Alaskans. You know, how does that work and how can we help? That was back in 2018 when we were still just you know, a graduate college research study, and so we have made a lot of progress since then. One of the things that we focus a lot on with logistics is that with our tool, we've created this almost Uber for transplant. These surgeons are able to provide their preferences of organ procurement. And what we're seeing and what our goal is to reduce the need for teams to travel long distances to get these organs, and that we could trust each other more to procure an organ. So why are we flying a team from Alaska down to Seattle to procure an organ when there's perfectly capable surgeons to procure that organ and send it on an already commercial flight heading in that direction? And so those are some of the things that we're working on. The other thing is, and oftentimes to get organs that far, we're talking about perfusion technology. And so how can we, it used to be that, you know, you kind of put it in a box, a vise, in an igloo cooler, and you send it on its way, and hopefully it got there. And they've made a lot of progress since then with systems like Transnet, which is a barcoding system to just make sure that it's getting tracked from the time it leaves the hospital, the time it arrives at the airport, to the time, so every time it transfers hands, it's being tracked. But there's still that when it's in the air, we don't know where it's at. And so one of the things that we focused on is these perfusion pumps. These perfusion pumps have made a lot of progress lately, which is allowing organs, kidney, liver, heart, lungs, to be able to be their life extended quite dramatically. We call it cold ischemic time, and the amount of time that they can spend outside of the body. And a lot of these machines are designed to fit onto planes. And we are working with those companies to connect those machines to our application so that we can track them, and that you can always monitor those kidneys on the way there. Should they start to have issues, you can let the team know right away that, hey, there's been an issue to the pump. Maybe you should, you know, bring in the patient and start surgery, because in some cases, like a heart transplant, you know, when the organ's being retrieved, they've already started opening up the chest of the recipient, so that by the time the organ gets there, they can put it right in. And so there's a lot of times where, you know, you don't want to ever have to put a person under surgery and wake them up and let them know that you didn't get the organ. And so those are things that we're focused on improving that cause a lot of problems in areas such as Alaska. And then finally, and this is where we're looking for help, is that not only with the organ procurement organization. So I'd say one thing is that OPOs like Life Center Northwest, whom we know their CEO, and we've done a lot. I mean, so much has changed since then. We use them as a great resource to talk and learn, but now we actually have a solution that I think could benefit them and also their their donor hospitals, their transplant centers in Alaska. Life Center Northwest is somebody that listens to people, and anybody that has connections, Life Center Northwest. Not that we don't have connections; it's just the more that they hear about these and have these questions, it inspires them to have conversations like this and to and to remember that these are things that they need to be thinking about. Not that they're not, but just to encourage those thoughts and make them further always present always helps. I'd say the other thing is that anybody that is involved or has been involved with kidney disease and knows some of the nephrologists locally in Alaska that may be having issues or problems with how to best refer patients or list patients for transplant. We are this is, if we're at phase 1, this is phase 3. So this is some time out, but we've been thinking about a concept. We call it, the idea is that it would be a patient-centric advocacy group that is focused on helping the patient multi-list and figure out, looking through the data, what's the best chance that they can have for getting a transplant. And that's connecting them to, in the case of kidney, for living kidney, and working with people like National Kidney Registry and National Kidney Foundation, but then also working with transplant center hospitals to figure out, we've got a lot of data that say if you're, this age, of this sex, and have this disease, we know surgeons that do particularly well and are very aggressive and have a lot of success with transplanting those types of patients. And so you might want to speak to them and list there. And so we are starting to do that. And one of the reasons that we're really excited about is not only is the patient need, but the payers. This is an opportunity in healthcare where saving the payers a lot of money also greatly benefits and brings a lot of great things to the patient. And getting a life-saving transplant, or in some cases a life-improving, enhancing transplant, is also, and particularly within kidney disease, a huge cost saver for payers. And so that's something that we've been working with politicians on, with large payers, is understanding patient population wellness management. And some of these geographically isolated patients, how can we increase accessibility to transplant? And then when we do, not only is that the patient wouldn't pay for it at all, this would be a service that patients could go to for free, that their payers would pay for, because it aligns everyone. It helps the patient. It also helps them save a lot of money. And so that is something that we've been working a lot on. And to any ideas in the group, or connections, or thoughts, or maybe other people or technologies that are kind of in similar spaces, that's an area of development that we're looking into down the road as we continue to grow our provider network, is to think about more direct focus on patients.
Well, first of all, thank you very much for that overview. What I'd like to do, that is entirely the purpose of HealthKai, is to promote those kind of innovative technologies. So trying to get all the people who are trying to do creative workarounds before with existing barriers is exactly the space that we want to be in. So now that we have that ask, we will definitely reach out and try to figure out where we can make connections here. I'd like to open it up for the group. Is there anybody online who would like to speak with Dalton and ask a question? No, we've got a few people with some backgrounds in healthcare that I can see on, but what I think that your work in the Northwest, and the fact that the logistics, I mean, so often the things that should be happening, like you were saying before about people, like why couldn't surgeons here in Alaska, rather than having a team go down to Seattle to get the organ? I mean, that makes such complete sense. And it sounds like you're in the communication space of trying to make sure that those, sometimes it's cultural, right? There's just a lack of trust. And so what you're able to do is kind of highlight how inefficient those are and try to get people to create new networks of trust. Is that part of what you're doing?
Trust is such a big part of it. That's so important. So important. It's one of the pillars that we talk about. I mean, you can make communication easier between people, but if people inherently have distrust, then you need to solve that first, and enable that. I think of it as Uber, and oh, that's crazy. I would never, get in a stranger's car, or Airbnb. I would never stay in some stranger's home. But the way that you can start to fight that, or at least encourage a change, is to increase transparency and trust. Who is this person? What are the ratings? Is this somebody that I can trust? And the driver likely also, who is this person that I'm going to be a ride to? How have other drivers rated their experience with this person? And those are things we're thinking about focusing on too.
Wonderful. I do have a question. I have one from Charles Nahibian, and he's asking if you're trying to solve the logistics problem also. And I think,
yep. So we don't have logistics services, in the sense that we don't have any of our own charter programs or charter planes or any charter services. And we also don't have like logistics management software. But we are highly interested in working with large logistics vendors or providers in your guys' area specifically, that we could work with as a partner that could get on the platform, and then we could tie in their logistics products to help with this. But yeah, it is something that's inherently like focused on what we're doing, but we're really communication centric, and we work with logistics providers to bring in those logistics tools and data, and we present that logistic data. But we rely on other logistics services to actually perform the logistics.
Okay, awesome. That's good to know. So maybe part of what we did, so the last time we actually had a group who provides healthcare services to their members, the Pacific Health Coalition, present. And I'm wondering if maybe a partnership with them might be a good idea. I'm sure that many of their members are possibly working with transplants. So maybe after this call, I can provide a connection to that. That would be awesome.
And I would say Life Center Northwest too, the OPO in Seattle, that's responsible also for Alaska. Kevin O'Connor is the CEO, and they're an excellent group. And so, I do think they're constantly thinking about how do we solve this problem in this Rubik's Cube. And so they're very, it's not that, I don't ever want to communicate that, there's definitely organ procurement organizations that, aren't as well ran and can improve drastically. And Life Center Northwest is one of those premier, leaders on kind of cutting edge and using technology to improve. We've been delighted to learn from them. Would love to work with them. But I just wanted to say that they're an organization that's thinking differently.
That's good to know. Thank you so much. And again, we're all about connections as well. This is not the last time that you're going to speak to us, for sure. We'd like to continue a relationship with you. So please follow up. Often after these calls, people are curious and they'll reach out to me. I'll share some follow-up emails. I'll definitely connect you to the Pacific Health Coalition and others now that I know more. I have a better understanding of what you need. So I want to thank you, Dalton. Thank you very much for telling us about this, but also thank you for doing it. It's clearly something that's really going to change lives and makes a big difference. So thank you.
Thanks. I appreciate it, everyone. Thanks for your time. If you have any questions, please feel free to share my contact information as well, Jacqueline, and I'd be happy to answer any questions.
I sure will. And thank you very much for your time. Well, I'm going to say good afternoon to everybody. Thank you for participating in the Health Tie, and thank you, Dalton, again. And we look forward to a continued relationship with you. So thank you.
Stay healthy. Stay safe.
Thank you. You as well. Goodbye now. Goodbye, everyone.